So having said that, you're going to see a lot of abbreviations for mostly these terms here. But so just learn what they are. I'm not going to go through what each one says. I'll introduce it at the time in which we talk about it. But mostly what we're going to talk about tonight that applies here is maybe cardiac output and how the heart creates cardiac output in conjunction with the actual heart rate. So just be aware of these terms. You need to look them up. I'm pretty sure they're always in the one, or there's always, the internet. So it's been a long time since you had A and B. Just remember where the heart is, how it's designed. I think that when you were in pediatrics, you studied a lot about the heart, transposition of the great vessels and all that jazz. So you can, but remember how the blood flows to the heart as well. But the heart is comprised of three layers: the endo, the myo, and the epicardium. And that's important to kind of understand, because when we get into actual pathology in this unit, we talk about epicarditis and endocarditis and things like that, so you can actually envision where the infection or inflammation is happening. The middle of the heart is divided by a septum, right? So if you have a septal defect, remember that in peds, because there's a hole in the septum, right? So a septum divides something, and then you have four chambers in the heart. So remember that the atrioventricular valves, let's break self-explanatory. So separate the atria and the ventricles, right? And then the semilunar valves separate the ventricles and the great vessels, the aorta and the pulmonary artery. Remember how the blood flows through the body. That's pretty important, especially when you talk about congestive heart failure. You really have to know how the blood is flowing so that you can understand the physiology of why you're getting peripheral edema when you have right-sided heart failure. So you have to kind of understand how the blood flows. All right? So be aware of that. Tonight we're going to talk a little bit about the cardiac conduction system, and also we're going to review some rhythms, some basic rhythms. But realize that the heart has cells in it that are designed to conduct electrical activity, and there's also cells in the heart that are designed to create electrical activity. Those cells that create electrical activity are the SA node, it's the pacemaker of the heart, and also the atrioventricular node, the AV node, which carries the impulse down to the ventricles. So realize that, like I said, the SA node is the pacemaker, the natural pacemaker of the heart. That's where the electrical activity originates in the heart, the SA node. It then travels through the atria, and then it goes down to the atrioventricular node. And the atrioventricular node sends that impulse out through the Purkinje fibers, the bundle of His, and out into the ventricles, and therefore causing the ventricles to contract. And also when the electrical activity goes to the atrium, they also contract. So this is a basic rhythm where you can see the components of an EKG strip. What we're worried about mostly is the P wave, the QRS, and this is the T wave. I think I put this picture here so that you could visualize the isoelectric line. So that's really important to understand, especially when we talk about a myocardial infarction, which is a heart attack. So this is the isoelectric line, all right? We just call it the baseline of the EKG rhythm. And we worry about that especially in this segment right here that's called the ST segment. We'll talk about that more later, but sometimes that segment can be below the isoelectric line, and sometimes it can be above the isoelectric line. So it's important to figure out where the isoelectric line is. So this looks like an actual rhythm, and the isoelectric line will be right about here, right? So it's just this line here. That's the isoelectric line. Just the baseline of it. I think I just put this here because it's a nice, pretty picture. But you can visualize that the electrical impulse originates in the SA node, and then it travels through the atrium to the AV node, bundle of His, and the bundle branches, Purkinje fibers, all that stuff. So that helps you visualize the movement of electrical activity in the heart. How about you? So, there you go. So these are the parts of the strip of the EKG waveforms that you need to be most concerned with. There are different areas, but these are the most important. So the P wave, like we said, is right here. All right. The P wave tells you that there's atrial depolarization happening. So that means contraction. So when you hear the word depolarization, it just means that that part of the heart is contracting. The PR interval, when we talk about an interval, we're talking about time. The amount of time that is lapsing. So when we talk about an interval, it's time. So the PR interval tells you how long it took the impulse to get from through the atrium. Because all of the atrial activity is occurring in that P wave, right? So the P wave is when the atrium contracts. And the impulse goes down to the AV node, and when you get to the R on the QRS, the bottom of the mountain there, that's the PR interval. Okay? So that tells you how long it took for the electrical activity to get through the atrium. And that's important when we talk about heart blocks in a few minutes. The QRS complex is the spike. It's the big spike on the EKG rhythm. Alright? QRS. QRS. QRS symbolizes ventricular depolarization, also known as ventricular contraction, right? The R wave is the top of the QRS. This is the P wave, that's an R wave. That's a T wave, okay? The ST segment is the time, let's see, so it's the end of ventricular depolarization and to the beginning of the resting cycle, all right? So there's this little section in there. The T wave is ventricular repolarization. So you think of repolarization as recharging. It's resting. That's when the SA node is getting ready again to fire out and make the atrium contract. So the ST segment is a very, very sensitive area of the EKG, and any external rhythm is introduced during that time, it can cause serious problems. So that section is important to be able to assess, especially when you are assessing the patient for a myocardial infarction. Okay? Heart muscle death. We'll talk more about that. And I just said the T wave, ventricular repolarization. And the R to R interval is the time between each ventricular depolarization, between each heartbeat, right? So the R to R interval, you're counting the spaces between the R to R's, and that tells you what the heart rate what the rate of the rhythm is, right? And I'll show you how to calculate that. Try not to get ahead of myself. So here's a little bit more. These are basic steps in beginning to interpret an EKG rhythm. On your rhythm strip, you'll see that you have boxes. So on that strip, you'll see some large boxes and some small boxes. Each small little box is 0.04 seconds. It's in time. But that 0.04 seconds is measured as 1 millimeter in distance. Okay, so each little box is 1 millimeter, but it's 0.04 seconds. Same thing, very different. Okay, so if you count 4 squares, how much is that in seconds? 0.16 seconds. Right, so that's important. It's very important for you to understand. And then a large square is 0.2 seconds, and that's simply because it's 5 small squares times 0.04 is 0.2. All right. And some of you may have had me in dosages, and I always told you, don't use a trailing zero, right? Well, this is not that. Right? But I don't know why we do this. We just say 0.20 seconds. I think you just count how we can figure out 2. But we're not going to overdose somebody by measuring through EKG with 0.22. When we are monitoring a general EKG rhythm, the patient's bedside monitor, we're not talking about a public EKG necessarily. If the patient is just on bedside EKG monitor, you walk in the room and on the monitor side of them is their EKG. We're probably looking at lead 2. There's lots of leads, several leads on an EKG that you can possibly look at, but we use lead 2 because it's the easiest to see everything happen. It's the prettiest. It looks the nicest. It's not necessarily the best one to monitor with. I think lead 3 is the best, but it doesn't look as nice, and we can't really see what's going on. So the first thing you need to look at is just the overall look of the EKG. You just need to glance at it first. And you'll learn normal sinus rhythm very well, and you'll be able to compare everything to that. You're going to look at the EKG, and you're going to be able to tell if it's regular or irregular. You're just going to see if those R waves look like they're equally spaced out. I'm not going to give you a rhythm on the test where it's like, it's going to be obviously irregular. Okay? Because you have an R wave here, here, and then way over here. That's irregular. Okay? But if they call it marching out. So if they march out evenly, there's about an inch between each one, I would say that's regular. You also need to assess the heart rate. There's two ways to do this. Each of those ways is in a different situation. The first one we'll talk about is the rhythm is irregular. So first you need to decide if it's regular or irregular. And if it's irregular, you simply find a 6-second strip that's 30 large boxes, and you count how many R waves you have. So you find a 6-second strip, maybe you got 8 bid, the heart rate is irregular. You just count how many R waves you have, and you multiply that by 6, and that tells you what, by 10, excuse me. You multiply that by 10, and that tells you about what the heart rate is. Okay? It's not a very specific way to do it. If it's irregular, that's how we do it manually. The machine does it, usually. But, you can do it by hand. The best way to measure a rate, and this is how you do it if the rhythm is regular. So if you have evenly spaced out R waves, you would count the number of small boxes between the R waves. It doesn't matter which one you use because they're all about the same. So just between two R waves, you would count the number of small boxes. And you divide that number into 1,500. And that gives you an exact heart rate. Okay? So in reality, what you're going to have to do with this is, I will give you a rhythm on the test and say assess the heart rate. Here you go. Right? Well, first you're going to have to decide. Take some critical thinking. Is this regular or is it irregular? Which method am I going to use? Can I count? Can I measure? Right? So I'll give you a nice little thing that you can count the boxes fairly easily. Right? And I won't trick you either. I'm going to say 83 or 85. It's either going to be, I'll space it out enough where it's obvious to me what the answer is. And if you calculate right, you will get the right answer. Okay? Some people will use the irregular method if it is a regular rhythm. So if it's regular, they print out a 6-second strip, count it, multiply times 10, and that's about right, but it's not exact. Dividing into 1,500, the number of small boxes between R waves is most specific. After you figure out what your heart rate is, you need to see if your rhythm has a P wave. Not all rhythms are going to have a visible P wave. If you can find a P wave, you will measure the PR interval. And your interval is measured in time. So a normal PR interval is 0.12 to 0.2 seconds. Anything over that is considered some sort of heart block. It's taking too long for the electricity to get from the SA node to the AV node. Then you will measure the width of the QRS interval. You want it to be no greater than 0.12 seconds. Also, you will glance at the T wave. Is there a T wave? Is it up like a mountain? Is it down like a bowl? Is it flat? You need to describe it. In clinical, you have that thing to describe T wave interpretation. So you might say round, smooth, and upright. That's a nice way to describe it with a T wave. Or it might be peaked because maybe they have hyperkalemia. Maybe they'll be depressed or inverted because they have hypokalemia. Right? Alright? Those are some basic things that you'll do initially when looking at this. So on your slides, maybe you can see the boxes, but look up here, and let's figure out how to assess these heart rates. Look at the top one and tell me, is that rhythm regular or irregular? It's irregular because you've got this amount of distance here, but then you've got almost double the amount of distance here, so it's irregular. Okay? This one is regular. See how nicely it marches out? It looks nice and pretty. It's all even. So how would we assess this rhythm, or excuse me, this rate? Right. Just count the number of R waves, and you multiply it times 10. So you've got 1, 2, 3, 4, 5, 6, 7, 8, 9. So this heart rate would be about 90. All right, that would be the correct answer. So how about this one? We said that it's regular. So we need to figure out how many small boxes are in between. What I do is take a shortcut. So I find one of the R waves that begins on the solid line. So this one looks nice. So we can go 5, 10, 15, and then you can count them right here. 1, 2, 3. So that's 18 small boxes. We can do that again. So this QRS is right on the solid line. Remember, the big box is 5 squares, right? So 1, 2, 3. So it's 15 squares, small squares. And then you got 1, 2, 3 over here. So 18. So 1,500 divided by 18. What is that? Everybody's phone's up here. So the heart rate here is 83. So what would we have gotten if we just did it counting? 1, 2, 3, 4, 5, 6, 7, 8. 8. That's not the same, but that can be the difference between 100 and 103. That would be described as normal, and the other one would be tachycardia, right? So that's how you do that. So do you see now why we can't do that with this one? Because this is going to give you a very different calculation than this is. Right? I said that there's we have just regular monitoring of a patient's EKG rhythm, and then we can do a diagnostic 12-lead EKG. What you're mostly going to be interpreting is just the rhythm from the monitor. It's not our job to interpret the 12-lead EKG. That's beyond our scope of practice. We can look at it and kind of know what it is, but somebody with higher training has to interpret that officially. So this is the placement of the leads. If you've ever been in the clinical setting, you will see that they have different colors. You've got 5 lead mods. These top leads should be somewhere up here in the left upper chest, below the clavicle, right? We prefer not to be on the arm. You can, but it's nice to be on the upper chest on the outside, but below the clavicle. The middle lead here is to one side or the other of the sternum, okay? About nipple line. Usually put it a little bit lower, but this is the correct place. And then you've got these bottom leads, which should be lower. Sometimes you'll see them real high or real low, but the mid to lower half of it is probably the best way to put it. This might seem insignificant, but it is significant. You have to be exposed correctly. You may not be monitoring the EKG properly. Sometimes you'll see just a 3-lead, and the 3-lead will be a white, a black, and a red lead. You put them in the same place, you just don't worry about the green or the brown. They will still go in those same places, just without these two. You can remember this, I think, because of the colors. I think the clouds go over grass, or snow sits on top of grass, and then smoke over fire. So you can remember that. This is the placement of the 12-lead EKG. It's one of the placements. You can kind of do it a little differently, but you've got a right upper and a left upper, and a right lower and a left lower, and then you got all these V leads. They're ventricular leads. They're right there looking directly at the heart. When you get into practice, you'll get very good at this, especially if you work in the field. A lot of times, we have EKG techs, and I think they're more meticulous about this than the nurses are. But they often will put these lower leads down on the legs. That's okay. It just has to be somewhere below the umbilicus. So if it's just below the lower abdomen, that's okay. If it's on the feet, that's okay. I better just reach out as far. But usually they put them on the legs. Okay? Especially this one is important to know, because you're dealing with that every day, all the time. Constantly replacing leads. So if the patient is getting a 12-lead EKG, these are some nursing responsibilities that you need to be aware of. It's a lot of assessment, but do realize that this is not an invasive procedure, so it doesn't require a written informed consent. It's just a verbal consent. You know, hey, Mr. Jones, I'm going to do an EKG on you. Okay, you know, there's your consent. It's not invasive, so you don't need consent. Some of your patients might be very hairy, and you'll just have to shave the hair off if you can't get the lead to stick onto your skin. Because if that lead doesn't stick onto the skin well and it's on the hair, it's going to be kind of jumpy, and you're going to get a lot of what we call artifact on the EKG. You're going to be unable to properly assess it. I think all that should make pretty good sense. One little pet peeve of mine or personal story is that, I've worked in the ICU forever, and patients come up from the ER all the time. Well, often when a patient comes into the ER, they get an EKG. And the nurses or whoever did the EKG will leave the leads on. Well, patients sometimes live a whole day in the ER, 8, 10, 12, 24 hours in the ER. And those leads, for the 12 lead, they'll leave them on sometimes. The patients like to think of that. But when I go to take them off, it's like pulling off silly string. It's just really annoying. And that's nasty. You can't get it off. I've even begged the patient to try to get it off and let it slip off. So when you're finished with the EKG, take off the leads. Okay? It takes 3 seconds. It's not time. It's just being lazy. So take off the leads. Make somebody's life easier a few hours later. So they probably don't even realize they're doing it, they don't, because they don't see the patient getting later. They're just there for a couple of hours, so they never have to take that. So this, take off. It's not a test. So this is more detailed about the parts of an EKG. So this is a really good picture. It shows you how to look at this. So we talked about the P wave and how it is atrial depolarization or atrial contraction. You don't need to know about the PR segment. So on your slide, you can just kind of cross out PR segment. What you need to worry about is the PR interval. Remember, an interval is always measured in time. So the PR interval is measured from the beginning of the P wave to the beginning of the QRS. In some time. So about what would this PR interval be? 1, 2, 3, 4, we'll say 4, right? So 4 times 0.04 is 0.16 seconds, right? And that is normal. You can measure the QRS interval. So you would measure from the end of the PR interval to the beginning of the ST segment. That's the QRS interval, this area right here. You want it to be no greater than 0.12, right? So this one is probably about 2, because it's 1 and about 2 halves. So that's 0.08 seconds normal, right? The ST segment, when we talk about things that are segments, we're not measuring anything necessarily. We're looking at it and just describing the way it looks. When we're talking about ST segment, we're either going to say, is it elevated? Is it on the isoelectric line? Or is it depressed? This one is where? On the isoelectric line. It's normal. The T wave begins at the end of the ST segment. This is a nice normal T wave. You see this is an alphabetical order. E, Q, R, S, T. Those are the things that are most important. Often, your patient might have a U wave that can be normal. Don't worry about it. It can mean that your patient has hypercapnia. Okay, so, and then you need to measure, we already did this, but you can measure the R to R interval. So for this practice EKG, we can actually measure the heart rate. So you have 1, 2, 3, 4, 5, 6. It's 18 here, so this heart rate's also 8. Alright? We couldn't really assess if this was regular or not, so we only got 2 RRs. 2 always. We only got 1 RR. So you need to be able to compare at least 2. But we're going to be looking at 6-second strip always. So more specifically about P waves, we talked that the PR interval is the time that it takes for the electrical impulse to get from the SA node to the AB node. You should have a ratio of 1 to 1. You should have 1 P wave to 1 QRS. That is normal. All of your P waves in general should look the same. They should all look about the same. They're going to look a little bit different every once in a while, but in general they should all look upright and rounded. Sometimes it might be slightly higher than the other one. That's not abnormal. But they should look about the same. You want to measure the height of the P wave. So you measure the height of the P wave from the isoelectric line, and then how many millimeters tall is it? You really want it to be no greater than 2 or 3 millimeters, the P wave. We can diagnose a patient with something just by looking at their P wave. They can either have P pulmonale or P mitral. P pulmonale is a tall P wave. It's a P wave greater than about 3 millimeters. That tells us that we have some hypertrophy of that atrium. And that tells us maybe the patient has some chronic hypertension, maybe the patient has heart failure. An M-shaped P wave is what you see right here. See how that looks like an M? It looks like 2 P waves. That's P pulmonale or P mitral. And you can remember P mitral is that it can tell you that you might have mitral valve dysfunction. Also, you may have left atrial enlargement, right? Yeah. Left-sided heart failure are also chronic hypertension. In chronic hypertension, the atrium are often very stretched out, and as they stretch out, the P wave begins to change. All right. Any questions about the P wave? So you want to measure the height of it and describe it. It should be no greater than 3 millimeters. Yeah, 0.3 millimeters is probably nearly microscopic. Yeah, people get confused a lot of times when they think about it. To keep the seconds and the millimeters separate. So just keep it straight. We talked about the ventricular depolarization, which is ventricular contraction, and is symbolized by the QRS wave. We talked about measuring the R to R. And all of your QRSs should, again, look about the same. All right? There shouldn't be a lot of variation in the height of the QRS in one rhythm. They should all have about the same width. We said that a normal distance or interval of the QRS is no more than 0.12. And these are some things that may be a problem if the patient has a wide QRS. We'll talk about a couple of ventricular rhythms, and you'll see that wide QRS. See, I get ahead of myself. So the ST segment, again, is where there's no electrical activity happening. It is a period of rest, and if there is any electrical activity introduced to the heart at that time in the cycle, you can throw the patient into the deadly group. You're thinking, well, how the heck is this? Well, you think about patients getting electrocuted. You also think about if you have to shock the patient who is not in a ventricular rhythm, but maybe in an atrial rhythm, and you forgot to put it on sync mode and you defibrillated him, well, you probably just let it go, right? So that's important to understand. I'll talk more about that probably on Tuesday. All right, and I think I already said this, but if the ST segment is elevated, that tells you that there's acute infarction. So infarction means cell death. And then ischemia means that there's a deficient flow of oxygen to that part of the heart muscle. And that is often symbolized by ST depression. People might have chronic ischemia of the heart muscle because they have coronary artery disease. So they might have depressed ST segment. They also, a person who has had an old MI or an old heart attack might have a depressed ST segment forever. So just keep those things in mind. But the most important thing acutely for us to acknowledge and recognize is an elevated ST segment. Because that patient is potentially a deadly situation. T-wave is recharged, is getting ready to depolarize again. And this section is also very sensitive. And I just talked about that. You also want to, like you describe the P wave, you want to describe the T wave. And I think I already said this, I'm going to get ahead of myself. But upright, round, smooth, it's not depressed, whatever, how it looks. So when you go to clinical next week and you get your patient's EKG rhythm out and it says T-wave description, you're going to draw a blank. Doctor's slides, and there's lots of examples of how to describe the T-wave. Okay? Everybody's going to be evaluating the EKG rhythm next week, or week after. Right? Alright? So, first we have to know normal. The most normal rhythm is normal sinus rhythm. We want to make sure that all of our components are here. We have a P wave, we have a QRS, and we have a T wave. And they're all in a ratio of 1 to 1. One P wave to QRS, one P wave to T wave, one QRS. There's one of each in each beat. You see that? P, QRS, T. It's all the same. We see that the R to R interval is regular. The PR interval is normal. The QRS is normal. The ST segment looks maybe a little bit depressed, but overall it's normal. And that T wave is nice and upright. The rate here would be what? 5, 10, 15, probably about 80. So that lies within a normal range for a heart rate. Remember the normal heart rate is 60 to 100. 60 is normal, 59 is not. 100 is normal, 101 is not. There's a lot. Pass it to 77.5, but don't pass it to 77.4. Right? Gosh, that would be the worst way to fail. Okay? So do you see that that is normal? Everything is normal. We didn't count the PR interval, but what is it about? 1, 2, 3, 4. That PR interval is about 4 to 0.16. Does everybody follow? Don't fall asleep. When I think about sinus bradycardia, I think about normal sinus rhythm. It's just slow. Everything is normal. It is sinus, meaning that everything is there. The electrical activity looks like it's originating from the P wave or from the SA node. That's what we call sinus. It originates from the SA node. Sinus. Everything is pretty much normal, except it's just less than 60. Occasionally, sinus bradycardia can be irregular. So you would call it sinus bradycardia with irregular. But in general, it's going to be regular. Okay, so let's talk a little bit about this, because this is a pathology, right? Realize that sinus bradycardia can be normal. Okay? Lots of you in here, your heart rate, as you're resting, is less than 60. I hope it is, because that usually means that you have a nice, strong heart. You often see this in athletes, in adults, and during sleep too, as you're resting. Your heart rate normally falls. So it's not considered too abnormal for you if you have sinus bradycardia. These are some things that are not so good that might cause sinus bradycardia. So when you've got an increased pressure in the head, you'll have bradycardia. Sometimes you'll have a heart attack. Sick sinus syndrome is a sinus node. Your sinus node is sick. So it's not putting out electricity often enough. It's often caused by chronic diseases. So these are other reasons. And this is this is an easy one for you to assess, right? Because beta blockers slow the heart rate down. So if you see bradycardia, you can assess and say, well, this patient's taking beta blockers. Probably not. So if you go to assess your patient, you go in on your first clinical day, and you walk in the room and you glance at the monitor and the heart rate says 50. Don't get excited. Okay? First thing you need to do is assess your patient. You don't treat the monitor, you treat the patient. The first thing that we assess if we see an abnormal rhythm is their level of consciousness. That tells us probably if they're symptomatic. So if you're waiting talking to me with a heart rate of 40, I don't really care, right? If you're walking around heart rate of 40, probably just fine. You also want to investigate further to make sure, obviously you already know the heart rate, but you want to assess the blood pressure. The patient may still be alert, maybe a little lethargic or offended, but you'll see maybe their blood pressure is pretty low because that low heart rate isn't producing enough cardiac output. So this patient is not getting enough blood to the brain, therefore they're not going to cognate as easily as someone with a normal blood pressure. Right? Does that make sense? So assess your patient first. So if on the test it said, student nurse entered the room, and this is what should be the first intervention. Assess the patient further. You would assess pulses because what are the pulses telling you? Patients producing cardiac output, right? The general rule is, an old nurse told me this, it's probably right, that if you can feel a radial pulse, the patient pressure is at least equal. That sound right? So, if you can feel a radial pulse, your patient's probably okay for now, but make sure that your patient does have a pulse. Your patient may be in a rhythm like sinus bradycardia, and they may need pulseless. It's called pulseless electrical activity. We'll talk about that later. All right? And then see if your patient is properly oxygenated. First assess, right? And we talked about that the sinus bradycardia may be asymptomatic, and we only treat things generally that are symptomatic. So if they're not having problems with it, they're maintaining good cardiac output with it, well, we might need to just decrease the beta blocker a little bit, especially if it's too low. Maybe take a look at some history or whatever, but you're only going to acutely treat it if the patient is symptomatic. And we talked about it. So the signs of symptomatic bradycardia are hypotension, decreased level of consciousness, possibly may feel like they're going to pass out. The patient may actually pass out. Maybe I'm going to do a little bit. So syncope, that means actually losing consciousness for at least a short period of time. And chest pain, because often an MI can be related to sinus bradycardia. If we have to treat sinus bradycardia, if we have to treat slow rhythm, if your patient is symptomatic, we're hard to browse, the pressure is 60 over 30, I hope that your first intervention will not be the fault position, right? You've got to do something for this patient now. I'm not going to let the head back, but what we're going to do in this, we are covered to give this medication without an order. We can give this medication based on our ACLS protocol. We'll talk about that more. But if your patient is in acute sinus bradycardia and they are symptomatic, you give them 0.5 milligrams of Atrial. You do it without an order. There is an order that you can certify as ACLS, and it's in the protocol. Please get it, right? Because we don't want the patient to die while you're waiting for the physician to come back. That would be really stupid. You'd be in court in front of a judge, right? So that's what you want to do. Clearly, you want to assess the patient's airway, make sure that it's patent. If you need to give the patient artificial breathing with an ambu bag, valve, mask, right? So obviously, we'd be assessing this patient's respiratory status. If we can't get the patient out of sinus bradycardia, if we're getting an atrophy and they're still low, they're still symptomatic, we can put them on a drip of medications. We'll talk more specifically about these medications, but you can put them on a drip of medication that keeps the heart rate up. It stimulates those beta cells in the heart and makes them work faster. Right? You can also get some more contractility from it too with these medications. Again, if the patient's symptomatic and you can't get the heart rate up, we can do pacing. Maybe you've heard of pacing the patient. Heard of a patient who has a pacemaker, right? An implanted permanent pacemaker. Perhaps that's because they have 6 sinus syndrome. The heart rate just won't stay up. They can't produce enough cardiac output. We can do transcutaneous pacing, so we can put the defibrillator pads on the patient's chest, and we can set it to pacing mode, and we can actually deliver shocks. It's not the most pleasant thing. Usually you would sedate the patient for that, but that's only going to be a short-term therapy because we can't keep them sedated, and it probably hurts a little bit. So then we can do transvenous pacing, where we actually put a central line into the subclavian vein, and we send the wire down to the atrium and send electrical activity down to that, causing that SA node to create electricity. That's still not permanent, but again, we can put put in a permanent pacemaker if necessary. Any questions about sinus bradycardia? And what do you do about it? Right? You have to be able to acknowledge it, assess it, and then act upon it, right? This one's easy too. So sinus tachycardia is sinus. It's regular. It's got all the components there. You've got a normal PR interval. You've got a normal QRS, and the T wave looks good. They're all there, 1-to-1 ratios. And so basically, this is normal sinus rhythm, but it's fast. Okay, it's greater. The heart rate is greater than 100. So 101 or greater. Not every fast rhythm is sinus tachycardia, but it's just a fast, normal sinus rhythm. What's the heart rate here? Did I already do it? 1, 2, 5, 10, 16. A little over 100. Well, sinus tachycardia, again, can be normal. Remember that, or you may not know this, so cardiac output, what is it? How do we get it? Cardiac output is heart rate times stroke volume. So if you increase either heart rate or if you increase the stroke volume, you're going to do what? Increase the cardiac output. So the heart will increase if your body is requiring more oxygen supply, needs more cardiac output, you will get tachycardia. That's why when you're running, you get tachycardia. Your body needs more oxygen. If a patient has something like congestive heart failure, a tachycardic rhythm could be dangerous. If any of you work with those types of patients, you probably tell them to do activity and do exercise, but within limits. You don't want them out running a marathon with just heart failure. They're going to get tachycardic, or cardiac output's going to fall out on the floor, and they're probably just going to die, right? So it could be dangerous for someone that has something like congestive heart failure. A common thing in the hospital, our patients are sick, and often they have infection, and the big sign of infection is fever. So often when the patient has infection and fever, you'll see tachycardia. It just goes along with it. The body needs more oxygen supply because it's at a higher metabolic rate, right? Your body is higher metabolism, creating a fever. So you need more oxygen. It's kind of interesting, though, because say, for instance, the patient had a fever of 102. Sometimes it coincides with the heart rate. So if you have a temperature of 102, the heart rate will be about 120. So you just drop that first zero, and it often corresponds to it. Isn't that interesting? I'm not sure why that happens. I don't know if anybody's figured it out. But sometimes it happens. But not always. You might have a temperature of 101, the patient's heart rate is 135. Well, there's probably a good chance that something other than that fever is causing that heart rate split. So, but generally, if the fever is caused, or the tachycardia is caused just by fever, it coincides. Exercise, fever, medications might increase it. What's the medication we just talked about that causes increased heart rate? Atropine, right? Why would hypovolemia cause tachycardia? The body's trying to increase cardiac output, therefore what does it do? It compensates by increasing the heart rate. This works initially. If your patient, if the heart rate is too fast, or it's fast too long, the body will eventually decompensate. If the heart rate gets up, 200, the ventricles don't even have time to fill, so therefore you're not going to have any cardiac output. So you'll decompensate sometimes, especially if you have a really high heart rate. Dehydration, hypovolemia, same thing. Anemia. So why would anemia cause possibly tachycardia? Right. So you might be anemic because of hypovolemia, but you don't have enough oxygen carrying capacity. So your cells are maybe deficient in oxygen. So your body's saying, hey, we need a higher heart rate so that we can get more cardiac, more oxygen supply. Okay. Shock in general is a low. Is a hypovolemia or low blood pressure. Okay, so there you go. If your patient is tachycardic, don't get too excited yet. You want to first assess your patient. So some of us, and I ask you tachycardic right now, maybe somebody's nervous. pressure's hot in here. So maybe this causes it to go fast. I don't know. So you want to assess your patient first. If we talked about how sinus bradycardia may cause low blood pressure because you don't have sufficient cardiac output. As part of that equation, trip volume is low, so you make low cardiac output. But with tachycardia, you would think, it's going to increase the cardiac output. Well, it does for a minute, but eventually it drops off. Okay, so you may have a patient with extremely tachycardic and hypotensive. That patient is symptomatic. Okay? Clearly, we want to figure out what is causing this tachycardia, try to fix that first. But we can give those medications that slow the heart rate. We can give them some beta blockers or some calcium channel blockers. When you're working in a high acuity area, your patients are going to be very sick, and often the culprit is hypertension. So if you give them a couple liters of fluid, it's fixing the underlying cause. Questions about that? Sinus arrhythmia, this one is also not a huge deal. It often doesn't cause any signs and symptoms. It's often asymptomatic. But this rhythm also is irregular, but it's normal. It still has the P, the QRS, the T. Everything looks pretty normal, all of your segments. It's just irregular. So if you assess this one, this is a normal sinus rhythm. Oh, but it's irregular. It's just sinus arrhythmia. Right? Arrhythmia means irregular. Often you'll see sinus arrhythmia in the young and the old. You guys did some pediatric assessments, you listened to their heart, had to take a deep breath, and you noticed their heart rate would change as you were listening to their heart, to their lungs or their heart. And it happens often in kids just by breathing deep. It causes the heart rate to slow down. But as you get older, that doesn't happen as much. And then older people will often get an arrhythmia. It might be sinus arrhythmia, or it might be a flutter, something like that. We'll talk about those in a little bit. What else? So you know that you've heard about the cranial nerves maybe. I'm going to drill into your head soon. But your vagus nerve, which is the 10th cranial nerve, has to do with your heart rate, your blood pressure. And if it's stimulated, you can quickly affect those vital signs. So maybe you don't have we call it vagal tone. So if your vagus nerve is easily stimulated, if your vagus nerve is, patients that may not have good vagal tone, that you quadriplegic. They have terrible vagal tone. Sitting them up, you might pass out. We're talking about that. And then medications may cause an irregular heart rate. I think digoxin is one that can cause low heart rate, but also arrhythmias too. We talked about HPs, but we're going to talk about it a lot of people. It's circulation system. So again, the first thing that you're going to do is assess your patient, right? I don't know how this got out of order, but the first thing you're going to do is assess the level of consciousness. That's your best indicator of some cardiac output. Because if a patient doesn't have any cardiac output, they are not going to get away. The brain's not getting oxygen. Like I said, generally this is asymptomatic. That doesn't require much of anything but monitoring. So this patient might go to the doctor every 3 months and they get a new patient. Make sure they haven't progressed into any more dangerous. Any questions about that? Keep going. Let me see how far I want to go. Okay. I'm going to do this. Just about 7 more slides and we're going to get out of here. So a PAC, a premature atrial contraction. What is that thing that's telling you? The atrium is contracting too soon, right? So in this rhythm, you can point out the PAC. So first thing you're going to look for, this looks pretty good, but it's irregular, right? So you look more closely at this. It's just one beat that's out. You see that this P wave jumped in too quickly. It happened too fast. Don't get this confused with sinus arrhythmia. Let's look at it again. Here we don't have a P wave that jumps in too quickly. It's still pretty regular. So look at this, the distance between the T wave and the P wave. The T wave of the preceding, the P wave of the next one. They're all about the same no matter where you are, right? But over here, this one's real short. See, I mean, it's just like a millimeter, 0.04 seconds. That's a premature atrial contraction. It happened too fast. The underlying rhythm is normal. This is probably a normal sinus rhythm, but it looks irregular where the PAC happened. It's going to jump in too soon, and you may have a prolonged period past that beat after the PAC. Well, this generally isn't a big deal. Just the SA node, we want the SA node to generate every beat. That's what we know for the patient's sinus. But sometimes the electrical activity can be originated elsewhere in the heart. Sometimes electrical activity pops up in the AV node too. Sometimes it originates somewhere in the heart muscle. Some pathology will cause this. So maybe the impulse originated somewhere other than the SA node. Let's see. SVT is supraventricular tachycardia. We'll talk about it. That's a really fast heart rate, and it can cause that. Like I said, PACs are generally benign, but those things that we Americans do too much are what cause PACs, right? Coffee, smoking, bad diet, all that stuff, drinking, stress, emotions. So I'm sure everybody in here has felt like, like a little something happened. That's probably a PAC. Right? It happens to me all. It's normal. It happens in everybody. But especially if you're stressed, you're drinking a lot of coffee, smoking a pack of cigarettes a day, before you test, whatever. It can cause that. And caffeine, of course, is a stimulant. All of these things are stimulants. And alcohol is a depressant generally, but initially when you drink, it causes stimulant. Then after a while, Mr. Napier talked all about that. So again, if your patient's having PACs, have a heart palpitation, I'm short of breath every once in a while, do an AKG, you have PACs. You're going to assess the patient first. Or if you're looking at the monitor, it's wrong, so you assess the patient. I keep saying that. Somehow I get it wrong. Beta blockers can help. So if the patient has chronic PACs, heart palpitations all the time, it's caused by nothing else, it's just regular PACs. You might want to load those for propranolol or something like that. Kind of slow the heart rate down, make it less excitable. That's maybe what we can do. But obviously we're going to try to cut these things out and try to fix those PACs. So I mentioned SVT, supraventricular tachycardia. When you think about it, supra means what? Above what? The ventricles. So this is tachycardia that is originating in the SA node. You can have ventricular tachycardia, right? That tachycardia is originating in the ventricles. But supraventricular tachycardia just means that the tachycardia is originating in the SA node. Often when you have this specific rhythm of SVT, some will call it PSVT, that's paroxysmal SVT, but when we talk about those things, they're kind of the same. I guess they're all the same. So often when you have SVT, usually the heart rate is greater than 150. So in order to call it SVT, you just don't probably more than 150. But kind of the defining factor of SVT is that you can't find a P wave. In this rhythm, you can see a P wave every once in a while, but right here, there's no P wave. Where is it? It's buried in that T wave preceding. It's hiding. You can't see it. It's happening too fast. The heart's happening too fast for the machine. You can find it. So when you can't find a P wave in your SVT, we'll say that the P wave is buried in the preceding T wave. Sometimes it gets buried elsewhere, but you just can't see it. So generally for an SVT, you're going to have an absent P wave, a heart rate greater than 150. Usually it's regular, but it can be irregular. So it's just really fast. Sometimes patients will go in and out of SVT. It's the paroxysmal. Why can't you measure a PR interval? You can't find a P wave. Yeah. said these things, I think. So that the nose may be irritable, causing this problem. And like I said, paroxysmal means sudden onset and goes away. It comes and goes. And this is something that's often seen, most often. I see it all the time. There was a couple of students last semester, or semester before, that had a patient in SVT, and they were symptomatic, and they were wanting to defibrillate or cardiovert him, and he was refusing because he goes in the SVT all the time. Yeah. So these are the signs and symptoms, right? Your heart's racing, or it's literally racing. Your heart rate's 150 or greater. It's a fast heart rate, and you can usually chill it. Assess your patient, okay? You assess SVT on the monitor. Don't just call the doctor and stand outside. Walk in the room and let out 4 or 5. Well, you take it slowly. And here we go. Those are some causes. We'll learn about hyperthyroidism eventually, and SVT is the most common, or one of the most common dysrhythmias in hyperthyroidism. When you're in hyperthyroidism, you're kind of like in a hypermetabolic state. This is coronary heart disease, also known as coronary artery disease. Pretty much the same thing. So this is what we can do, or what can be done for a patient who is an SVT. Maybe one of the first things that we would ask the patient to do is perform a Valsalva maneuver. And this is where you cough, take a deep breath, and bear down like you're having a bowel movement. You can tell them to do that. And sometimes that will lower the heart rate. And that works because by doing that, you're stimulating the vagus nerve. And the stimulation of that vagus nerve might bring down that heart rate. It often works. One thing that can also be done is a carotid massage. If you remember from A&P, you remember that the carotid arteries in the arch of the aorta have what are called baroreceptors in them. So those receptors respond to pressure from the vessels and therefore decrease and lower the heart rate downwards. So if you have low cardiac output, not a lot of pressure hitting those baroreceptors, your heart rate's going to decrease. So that's kind of how it physiologically works. So if we can manually stimulate those baroreceptors, we can maybe get that heart rate to come down. Keep in mind that we don't do this. Okay? It is done, but we don't do this. Because it can often be very effective. Your patient may be really bradycardia and go out on your pulses. So I don't want that to happen. So we leave this to the physician or someone with a higher license than us already, right? And sometimes it's really nice to not have to do things that are pretty risky. My license sake, and another thing is that you want to make sure that when this is being done, that whoever's doing it is not doing both sides at the same time. Because what can happen there? You're going to cut off oxygen supply to the brain. Right? So it's a deep carotid massage. Adenosine will lower the heart rate. Adenosine is a very interesting medication. It's called, I think, Anticard is the trade name for it. If any of you paramedic EMTs are in here, you've probably used it before, or seen it used, or if you work in ER, maybe you've seen it used. It's really neat. So the patient will be extremely tachycardic, they're symptomatic. We can't get any of these non-pharmacological interventions to work. So what we can do is give them a medication called adenosine. Usually, I think you give 6 milligrams. That doesn't matter. Yeah, you can give it twice if you need to. But you push it really fast, as close to the heart as possible, so maybe an upper arm IV. You push it really fast, and flush real fast behind it, and it just goes into the heart, and it actually stops the electrical activity in the heart for a short period of time. So it's scary when you see it. So you can give the medication. It doesn't always do this, but sometimes it slows down. But often what it'll do is the heart will just pause. You'll get a flat line. It might kind of hold their breath for a long time. And then it'll pick back up. And hopefully it'll be in a lower, more normal rhythm, right? If it doesn't work, you can give it again. And I think you max out at a certain. You can only give it twice, right? Yeah. So you get 24 milligrams of it. Yeah. So, but you don't have to know this. You're not ordering. But it's your gift. Beta blockers, most specifically, will lower the heart rate. Calcium channel blockers, some of them can do so. When you go into your mini pharmacology book tonight, you're going to be researching maybe peptides and arrhythmia, and you're going to see how these medications work. There's different types of beta blockers. Calcium channel blockers. Some lower the heart rate, some don't. Right? This patient may be hypoxic. You might need to get him supplemental oxygen. The body is just using up a lot of oxygen in a hypermetabolic state, and we can give them supplemental oxygen if necessary. And I also talked about cardioversion. This is not one of our first actions, it's last, but it's painful for the patient. It's considered invasive. The patient does have to consent to this unless it's an emergent situation. Just do it. But oftentimes these patients will be awake talking to you, and but you would have to sedate the patient if they're not unconscious already, and then we can shock them. There's two types of shocks, if you didn't know that. There is a cardioversion, which is a synced shock. It's synced at a specific time in the rhythm. I think it hits right on the QRS, and then the machine does that for you. You don't have to, and then at defibrillation, it just shocks the rhythm. So, anyway, and obviously, what I would do is I would assess the patient. I would have them bear down, see if I can get that heart rate down, and then call the physician. Try to do something first to see if you can get the heart rate down, because the patient may soon decompensate and lose their cardiac output. So in the meantime, you can buy them a little time before the physician gets there and order some medications for you to give. All right? Any questions about SVT? It's pretty neat for 20 pounds. It's not good for the patient, but it's an emergent situation. Though. You've got to get this patient out of SVT. You're going to decompensate. So it's high adrenaline when it happens. That's a lot of fun. Technically, atrial flutter is a supraventricular rhythm because this rhythm is a problem with the supraventricular area, the atrium, right? But it's not paroxysmal supraventricular. It's a flutter. When I get to the end, I'll kind of review all this stuff. But when you see a flutter, it's one of those rhythms that you'll be able to look at and immediately know what it is. You don't have to do anything other than look at it. You see how unique that looks? We call it a sawtooth appearance. It looks like a saw. Okay? If you see that, you're immediately going to know the patient's an A flutter. It's one of those that you automatically know. You're probably going to automatically know normal sinus rhythm. You're going to automatically know A flutter. Probably automatically know A fib. And then you'll hopefully automatically know ventricular tachycardia, ventricular fibrillation. If you don't, you got a problem. So this rhythm is probably not sinus. There are impulses happening elsewhere than the SA node causing the atrium to contract. So something is going on here. The atrium are contracting too often. You can't measure the PR interval because you can't decide which one is the correct P wave, right? Which one's the real P wave? Which one is a T wave? Is that a T wave? Is that I don't know. So you really can't measure a PR interval with the QRSs usually look normal because there's really nothing wrong with the ventricles, supraventricular. And this is the ratio, right? So that tells you that when I say 2 to 3 times more P's than R's, that means that your atrium are contracting 2 to 3 times as often as your ventricles. So that's abnormal, right? Because in normal sinus rhythm, you've got a 1-to-1 ratio. So usually 2 to 3 here. So therefore, you can have a really high atrial rate, so lots of P waves, and the ventricular rate is fairly normal. That can be the high end. Okay? This one is regular, but it can be irregular. But, you'll find that when I'm talking in class, I try not to say absolutes, because there's nothing that is absolute. Right? That's really the hard thing about healthcare studies. Sometimes it happens, sometimes it doesn't. Usually, not always. So, but with A flutter, you're just going to say, that's A flutter. You're not going to have to measure anything. All right? It's going to pop right out at you. I talked about maybe the impulses occurring somewhere else, but with A flutter and A fib, atrial fibrillation, which we'll talk about next, the impulse for some reason can't escape the atrium. So you have it's called a re-entry syndrome. Maybe you've developed more or had too many, or some of the heart material or muscle has become sensitive to electrical activity. So it's kind of arcing back. If you know anything about electricity, it's kind of arcing. It's coming back where it's back to the SA node and it's regenerating it too quickly. So just think about that electrical activity spinning around in the atrium. And every once in a while when we get out of the SA, use that as normal. Does that make sense? So it's a re-entry syndrome. The electrical activity is staying there for some reason. And these are some more causes, okay? Thyrotoxicosis, that goes along with hyperthyroidism. So you're seeing some of these are similar. So these kind of went along with an arrhythmia. And we said that sinus arrhythmia can lead to further complications. Coronary artery disease, myocardial infarction, pulmonary embolism, and valvular disease. So just so you know what those mean. Here we go again. That's your patient. Right? I think you're going to get that test question right. I hope so. This patient is going to have heart palpitations. They're going to say, I feel like my heart's in my throat. And maybe you feel that way when you have a PAC too, but it passes. So a flutter, the patient is going to be feeling this pretty continuously. Hypotension, and those signs of hypotension, some of them are diaphoresis, clammy skin. If you've ever gotten near syncope, you probably felt pretty clammy and maybe got sweat, right? It's probably happened to somebody. Yeah, I know. We're all excited right now. And these are medications, again, that the calcium channel blocker and the beta blocker are going to help lower the heart rate, and the amiodarone is an anti-disrhythmic. So this is going to restore the normal rhythm of the heart. We'll talk more about it. In general, when I mention a medication, I may not have time to talk about it in depth, but you have a leading pharmacology book and you need to understand it. But you're probably pretty good at a lot of these. You guys have this lecture from Ms. Cummings. Who teaches it in transitions? Aren't you helping out? Taylor. The Digoxin we usually don't give to a patient with a flutter. We can give it to a patient that has atrial fibrillation. This patient is slightly at risk for developing clots in the atrium because of this rhythm, because the blood is not exiting fast enough. It gets stagnant in there and it can clot. There's not as big of a risk of that with this rhythm as with a flutter. We'll talk about it in a minute. But generally, when we talk about cardioversion, you kind of have cardioversion where you shock the patient from the right? So generally we don't want to do that if we know that the patient has been in this rhythm for more than 48 hours, or the patient has been in this rhythm for an unknown amount of time. Because at that point the patient may have actually developed clots in the heart. Then you put the heart back into a regular rhythm. What's going to happen? It's going to pump right out, right? So we're going to anticoagulate that patient first. So you're not truly anticoagulated until about 2 to 4 weeks after starting warfarin. You guys have talked about Coumadin and warfarin before. And you know that with Coumadin and warfarin, it's the same medication, but there's two things. It increases the INR. The INR is a calculation of PT. It's an international normalized ratio. So you want the INR to be 2 to 3 times normal. So a normal INR is what? 1. Okay? You're going to go get your patient information, and you're going to look at the coags, the blood clotting studies, and you're going to find INR, and you're going to see that the INR says, 1.1. That's pretty normal, right? But the reference range is going to say 2 to 3. And you're going to be searching. Why is this INR low? It's really not low. Okay? A normal INR is about 1. And every INR is specific to that one patient. It's not a standardized range. It's calculated based on what the PT is. And it's compared to a normal PT. So, just know that a normal INR is 1. And for the patient to be effectively anticoagulated while on fluid and warfarin, their INR should be at least 2. Some say 2.5. Okay. So, you understand why the patient should be anticoagulated if they've been in this rhythm for a long time. You don't want to shoot out a clot and cause them to have what? PE or to have a CDF. All right. When you think about AFib and A-flutter together, they have similar treatments and they have similar causes and things. But with AFib, it's not sinus again. This is not originating from the SA node necessarily, and it is irregular. AFib is always irregular. You see that irregular heart rate? The nice thing about atrial fibrillation is kind of a hallmark sign of AFib is that it's irregularly irregular. Well, it's not sinus, it's irregular. And then it's irregular because it's in a rhythm. It's the R-to-R type. So it's irregularly irregular. This is all messed up. So you may have an atrial rate of 300 plus. You see all this junk here? This is fibrillation of the atrium. So that it might fibrillate 300 times a minute. Do that. Okay. You can't measure a PR interval. Why? There is. Which one do I choose? Is that a D wave or not? You know, it's just a bunch of garbage there. First, you're going to want to make sure that it's not just artifacts on the EKG read. So once you assess that, then you can probably assess it for the AFib. And like atrial fibrillation, your heart rate might be a little bit high, and that's because you've got a lot of atrial activity and it might be shooting out to the AV node pretty quickly. So high normal with AFib. Sometimes it's low, but whatever. So what you're gonna see is this junky stuff in between R rates, and you're gonna see irregular R rates. This is one that you're just gonna look at and hopefully say that's AFib. You should be able to identify pretty quickly because you really can't measure anything, right? So the T waves in A-flutter are distinguishable. You're not sure if it's a T wave, but you can see the T wave. It's more uniform. But in AFib, see, it's just looks like artifact. It looks like trash. These are some of the descriptors that you're going to see maybe on test or NCLEX, is that it's disorganized. It's a rapid, ineffective rhythm. It's irregularly irregular. So when you think about fibrillation, you normally hear this with ventricular fibrillation. Clearly, it's a deadly thing, but it's fibrillation means quivering. So the atrium is quivering. They're not really contracting, they're just quivering. And when you have this quivering of the atrium, they're not contracting, pushing that blood out again. That blood's going to congest, get stuck in the atrium. It's not going to move around very much. Therefore, it's going to be maybe clot. So this patient is at, again, risk for CVA and a pulmonary embolism. All right. Most likely, it's going to cause a CVA. It's going to cause a stroke. Most likely going to go to the head. Here we go. Hyperthyroidism. Just remember, we'll talk more about this later, but the most common dysrhythmia in hyperthyroidism is AFib. Number 1. Why might you have this rhythm decrease cardiac output? Yeah, well, the atrium don't push the heart out of the body. You're not having proper ventricular filling, right? So when the blood's kind of hanging out in the atrium, right, you might have dominated atrium. So you're not getting good preload. The preload is the blood that's ready to be injected. Right? The end-diastolic volume, that's what we call it. But yeah, so you're not getting a good amount of blood to be injected because it's not being effectively pushed down into the ventricles. So this is repeating again. This patient is probably going to need some sort of IV medication. The patient can be cardioverted, but again, you don't want to cardiovert if the patient has been in this rhythm for an unknown amount of time, or they have been in the rhythm for a known time longer than 48 hours. If the patient does not have a history of all of this, they come in and they acutely go into it in the ER. We can cardiovert them quickly and try to get them out of it. But chronically, that is not going to be a treatment. Chronically, this patient is probably going to be on some verapamil, some metoprolol, maybe on the Johnson. Remember, amiodarone is an anti-dysrhythmic, so it's going to restore, hopefully, that regular rhythm of the heart. Be very familiar with the use of warfarin. Nurses manage this all day long, just by protocols and our normal ranges. So, Meemaw's on Coumadin. She goes to see the nurse practitioner every 3 months. It's probably the RN that is the one that is drawing, assessing, titrating that medication. But I think some of you might want to find that here. So it's managed by protocol usually. So you need to know a lot about this medicine. We teach the patient about this medicine. I think a misconception that people have about Coumadin and warfarin is to teach your patient not to stop eating and drinking dark green medications. That's not true. You should teach your patient to not change their intake of dark green vegetables. So if you have 3 servings of collard greens every week, don't go crazy and have it every day. Because what's going to happen? Your IR is going to come down again. You're not therapeutic. That's what is in dark green leafy vegetables. Vitamin K, which is the antidote to conduction. So we want to leave this patient in a state where they're happy. They like spinach. That's okay. Just don't go eat a whole bag of it. Just keep it steady. Right? Don't change too much. All right. Pradaxa is a fairly new medication. It's been out a few years. Pradaxa is nice. You do have to take it twice per day as opposed to once a day with Coumadin, but it doesn't require all this INR on it. But it's very expensive. Warfarin, Coumadin, or warfarin is not expensive. Coumadin is. You know that they're both warfarin, but the thing is, that's the last thing about that. When the thing about warfarin is that if you're on warfarin, you need to stay on warfarin. If you're on Coumadin, you need to stay on Coumadin. You can switch, but it might be a challenge. So, and the reason for that is because INR has a narrow therapeutic index. So we want that INR tightly between 2 and 3, 2.5 and 3.5. It's a tight range. Any slight change in doses can make a big difference with the medication. When you think about medications, trade name versus brand name, really the only difference is the difference in bioavailability. Bioavailability is the amount of usable molecule in that medication. So warfarin has a lower bioavailability. So if you're taking 1 milligram of warfarin, I'm taking 1 milligram of Coumadin, I'm probably getting a little bit more. It's more pure. Okay, it doesn't have as many fillers. So when you take Coumadin, often the patient will need a lower dose. Okay? So it's the principle of bioavailability. How much usable molecule is there to be absorbed. So write that down. So that's what that means. And that's why. Just what's the other medication that you can't change? Synthroid. You guys know what Synthroid is? We're talking about levothyroxine. It's for hypothyroidism. It's T4. So it's a style of hormone. And that's another thing. It's a narrow therapeutic index. Narrow normal range for that T4. And any slight change in the dosing can be a big difference in the therapeutic. So if you're on Synthroid, you need to say Synthroid from levothyroxine, you should stay on it. It's a therapeutic. If you go to the pharmacist and the pharmacist has had a brain fart that day and they're like, I want to switch to generic, it's cheap. Okay, so you go to the Synthroid and levothyroxine, well, then the patient's going to start having sinus symptoms of hypothyroidism because of T4. That's not dangerous. It's a low therapeutic index. But that's the reason. Bioavailability. That's the difference between trade and generic. You guys know that? So, warfarin has a lower bioavailability. Just think about it, probably has less medicine. I think 1 milligram of warfarin is what? You probably need a little bit lower dose. Yeah. But if that had to happen and you convinced your prescriber to do that for you, it would be like going back to day one. All right, got to come in every 3 days and you got to check your INR to make sure that it's staying good. And a high INR is very dangerous. So make sure that you know that. So I've seen INRs of 12, 14. So this patient is a big risk of bleeding, right? So, and that's where you're talking. We're not going to talk. They're going to stop the 2 minutes. I'm going to give them vitamin K. Alright, so we're going to stop at atrial fibrillation, and we'll pick up on Tuesday. Will we be here Tuesday? Yes. We'll pick up Tuesday. Hopefully they'll have the air kits by then, and we'll start talking about heart blocks. So, but what you need to go home and do is have a good understanding of these segments, the descriptions of the P wave, how to measure it, be able to evaluate some basic EKG readings. So this is the time to really focus on. The time is not to focus on in a couple of weeks when you really should be focused on just heart rate. Right? So now if you really want to study EKG rhythms, do it this weekend. But I'll leave it this weekend and just review it after that. But get good at it, get fairly good at it, and know those rhythms that we talked about that you can really point out. Point out egg flutter, point out egg fish. There's some good online websites that are free that you can look at. Maybe people might have some of those websites that you can look at and test yourself. Go for it. So look around on Google. So send me an email if you need anything. This lecture will be recorded and will be available soon.
You want us to leave